today is advocacy, accountability, values, and ethics.
Yes.
All right. Sounds fun, doesn't it? So, let's talk about what advocacy is. Basically, an advocate is someone that protects or defends someone else's cause. And one of our roles as a nurse is to act as a client advocate. Okay? Basically, one of the things they're supposed to do is defend them from harm. Making sure that their needs and wishes are represented to others. Whether it be to the physician, whether it be to a surgeon, whether it be to respiratory therapy, occupational therapy, etc., etc. We want to make sure that whenever we're planning care, that they have a voice in what that care would be and make sure that their wishes may be heard. Now, that doesn't mean all the time that their wishes can be followed to the letter. But what's going to happen if we don't take those wishes into account whenever they're discharged from the hospital?
They might sue us.
They're not going to comply, or they're not going to follow through. And they're not going to have the care that they need and deserve. Basically, what we want to do is to make it a very positive experience for both the nurse and the client, because you know that a lot of times we say, well, you know, if they would just take care of themselves, they wouldn't be back in this hospital again. The thing is that what we have to do as nurses is advocate for that client and find out why are they not taking care of themselves in the way that we think that they need to be. They may be doing the best that they can with the amount of resources that they've got. And you need to make sure that if they don't have those resources, that you at least try to provide them with some type of resource. The other thing that you need to think about with advocacy is that the advocate sort of helps navigate a very complex health system. I know that one of the things that a lot of hospitals are developing are what they call navigators, okay, like the breast health navigator or the cancer care navigator or whatever. That nurse is an advocate for that client to sort of help them through the process. It's a familiar person, no matter where they are in that healthcare system, to sort of help them sort of figure out what's going on, where do I need to be, and who do I need to see, and what resources are available. Have any of you worked with any of the navigators in the hospitals on the units? Okay. With the navigators, typically what you will see is those folks are people that not only follow them inpatient, they follow them outpatient. A lot of times what you will see is, especially the breast health navigators, will come and visit those patients when they're in chemo or radiation therapy to make sure that they know exactly what they're supposed to be doing. It is even though all nurses advocate for their patients, this is a nurse that has been designated specifically by the hospital to help that person be an advocate for that client. And what they try to do is to help penetrate the bureaucracy of this system. If you can imagine someone that comes from, I'm not picking on Stanley County, but I'm going to just say Stanley County, coming to Charlotte okay, if they've not made the trip into Charlotte. Can you imagine how frightening, how very unnerving that could be to come into that big hospital, that CMC Maine, with this big complex and parking issues and I don't know where. Whenever they're used to their nice little hospital where you just park, you don't have to worry about paying, you just walk into the hospital. Okay? It gets very, very overwhelming for a lot of these patients. And what we see is that as a lot of our hospitals become referral centers, CMC Northeast is becoming a referral center for some of the other rural counties. We see a lot of patients that come from Stanley County into CMC Northeast. We see a lot of patients come from Union County to CMC Northeast. When I worked at Duke, and some of you have familiarity with UNC hospital systems, those are statewide referral agencies. The Baptist in Winston-Salem is a referral area. And what you find is that patients are very overwhelmed at times, and they need someone to sort of help them through that bureaucracy and make sure that not only do they get what they need while they're at that center, but how are they going to take care of themselves whenever they go home? Okay? So becoming an advocate is a way that we protect those clients' rights to health care. One of the things that we do as an advocate is to make sure that we provide them information. We do not want to make a decision for them, because unfortunately what happens is that a lot of times is that that's what is done. You need to have this done on this day, at this time, be here or be square, so to speak. But I'm sorry I can't be there at 9 o'clock. I don't have child care until 11. You know, that is something that you need to take into consideration whenever you're caring for these clients. You know, not only is that woman your client, but that family is your client as well. And if they're unable to take care of their family, as women, a lot of times what we do is put things off because, you know, it's our responsibility to care for the family. We want to make sure that we support them in making informed decisions. You know, the thing is that often what you'll find is physicians will give, well, you have your choice of this treatment or this treatment. Or, you know, they put you on this medication, and then you learn at the pharmacy that, well, you can't take this because it interacts with one of your other medications. You know, one of the roles that we have as nurses to make sure is that that drug reconciliation is completed so that the physician or healthcare provider is very aware of what other medications. Because if I go as the patient, get that prescription, go to the pharmacy, and the pharmacy says, well, I can't give you this because it interacts with your Coumadin, then what am I going to do? Do I have to go back to the physician, or is the pharmacist going to advocate for me? Or if, you know, what decision am I going to have to make? And, you know, unfortunately, the way it happens is that if I have to go back to the physician, what's that going to do? Yeah, I'm going to have to charge another copay if I have insurance, but if not, I'm going to have to pay it out of pocket. So think of things like that to make sure that these patients are very well informed whenever they do make the decision. The other thing, of course, is working as a nurse advocate is you have to work with clients who lack that decision-making capability. Patients that have low literacy, patients that don't speak English, or sometimes that are very, very poor, or just too sick to make a informed decision. We have to act as their advocate. What effect will low literacy have on making decisions about health care? Typically what happens with patients whenever they're, well, you have a choice of this or this. They either agree with what you say or, well, whatever you think is best, okay? Versus, well, here, read about this, and then there's this other option. Read these and let me know what what your decision is. Or they don't have the capability of Dr. Google and figuring out what the best option might be. People that don't speak English, or do speak English but have minimal comprehension, are also a group of clients that we definitely need to advocate for. There was an article in the paper that was found very interesting, and they're looking at a study on the Hispanic population in Charlotte-Mecklenburg area. And they were looking at the use of the emergency department as their primary care area. And what they found is that two things. Number one, they could go whenever they got off of work, or whenever they were able to find transportation. Number two, they always had an interpreter so that they could understand what was going on. And the other thing that they found is that they used the emergency department primarily as primary care because that's what they did in their countries that they came from. They typically did not go to a doctor unless they were very, very ill, and if they did, then they went to the emergency department at the hospital. Okay, so basically what they're trying to do now is to come up with a clinic, so to speak, like an urgent care that's attached to the hospital, or that has these alternative hours that always has a translator available. And what they're trying to figure out is how do they get that information to the Hispanic populations so that they can have appropriate use of the ER facilities and the clinic facilities. So, unfortunately, what's happened is that a lot of these patients have gotten horrible bills from the emergency department because that's their only alternative for care. So I'll hope to see what the clinic is going to do just in the future. The other thing you need to think about as an advocate is that in some cultures, it's a very Western view of philosophy that patient is the one that makes the decision about their health care. The patient is the one that you inform of the test results. The patient is the one that ultimately decides. That's a very Western philosophy of medicine. What we typically see in other cultures, especially if they're patriarchal societies, meaning the man is the head of the household, it may be the head of the household or the eldest person in that family that makes that decision. You will see that with a lot of Hispanic cultures. You will see that with a lot of Asian cultures as well. It may be the oldest person in the family, whether it be male or female, that makes the decision about what health care would be. A lot of cultures, it may be that it will be due to what role that person plays in the family as to who is the person that makes that final decision. And one of the things that you're going to see is that if you do not include that family member and consider their cultural background, then it doesn't make any difference what that patient decides. It's going to be what the head of the household is going to say that makes that decision. These are some basic values whenever you're talking about client advocacy. And again, this is very much a Western philosophy. The client's a holistic, autonomous being who has the right to make choices and decisions. The client has a right to expect a nurse-client relationship based on shared respect, trust, collaboration, and solving problems. The nurse has the responsibility to ensure the client has access to healthcare services that meet health needs. And those are just some basic values. One of the things that you will see is that now hospitals have what they call the Bill of Rights, Patient's Bill of Rights. And if you ever go into the hospital, you are given a copy of those with what rights and privileges you can expect whenever you go in there. One of the things that you will see when we act as advocates is that we have the right to be assertive for that patient's needs and wants and wishes. We need to recognize that the values of that client and family can take precedence even over what we consider the best medical care that they need. And what you're going to find is that sometimes conflicts can arise. One of the clients that I took care of had ALS. And I think a lot of you probably know what ALS is because of the wonderful Ice Bucket Challenge. By the way, that was the most successful fundraising thing that has ever happened in the United States. In fact, the amount of money that it brought in basically surpassed Susan G. Komen in the amount of money that it brought into the ALS Society. ALS basically is a progressive fatal neurological disease. Typically what you will see is that as the disease progresses, patients will become either ventilator dependent or they will die because of respiratory dysfunction. We had a client with ALS that came in with pneumonia. Her wishes were such that she did not want to go on the ventilator because she knew that she probably would not come off or it would be very, very difficult to come off. She had pneumonia, a very treatable disease. But she knew eventually that she was going to die because of this respiratory problem. Her decision was that I don't care how bad my pneumonia gets, you give me antibiotics and that's the only treatment I want. I don't want to be on the ventilator. The physician did not agree with that decision. And basically it was a very highly controversial decision because the physician felt they have pneumonia. If she has to go on the ventilator, it'll just be a little time and then she can come off. But her decision was that I don't care, I don't want to be on the ventilator for any reason. Eventually it went to the ethics committee and the patient's wishes won because they recognized that this woman did have a fatal disease that if she went on that ventilator and was not able to come off, then that would be what the rest of her life would be in the hospital on that ventilator or at home or a nursing home on ventilator. So it was one of those things that basically the physician removed himself from the case because he could not live with that person's wishes. But all of the nurses felt that that woman had the responsibility and she was well informed that she was able to make her own decision. Basically with your developmental considerations. You're going to advocate for safety, looking for vulnerable clients. And here we're talking about children, older adults. We're talking about women that are in the situation where we have intimate partner violence. And I think that one of the things that's really brought intimate partner violence to the forefront has been all of the cases that have been in the news just recently. I think that one of the ways that we can advocate is to be alert for those signs of abuse and remembering that it crosses all races, creeds, economic levels, and we want to make sure that we screen everybody for potential of abuse, whether it be intimate partner, whether it be child abuse, whether it be older adults, whether it be the mentally challenged. We want to keep them safe and make sure that they're educated about their options. Home care. Okay? One of the things that you need to remember about home care is that when the patient is in the hospital, basically the majority of time they operate from the values of the nurse and the healthcare providers. And they usually will follow instructions and comply with treatment. But what happens when they go home? Whose values are they more likely to be influenced by? Their own family, their own values and wishes. Okay? So typically what you're going to have to do is to make sure that these patients follow through, is make sure that they've got the resources available that they need. One of the clients that we took care of that we sent home with dressing changes, when you're teaching someone how to do a dressing change, what's one of the first things you tell the patient to do?
Wash their hands.
He had no running water in the house. So how does he wash his hands? Had to come up with a way so that this guy could wash his hands. Okay? And that would involve heating water on the stove and washing his hands that way prior to doing his dressing change. Look for the resources. You know, just one of the things that we always assume is that everyone has the same resources that we have at home, and that is not always the case. That is definitely not always the case. It's just like the old joke where they had the recipe book, and it says, you know, Dave, you know, how did you like using that recipe book? He says, well, I threw it away. He says, well, why? He said, well, it always said start with a clean pot, and I never had any. Didn't want to buy a pot every time I did a recipe. All right, empowering the client. We're going to support and advocate, and that may be coaching, informing, or explaining. One of the things that we want to do is to make sure that clients are able to do what they need to do. Occasionally, we're going to help them along with that. But one of the things we don't want to do is to do everything for them. Okay? It's sometimes a whole lot easier to just do it than to wait until they are able to do it themselves. For example, some of my stroke patients that may be extremely messy with feeding themselves. You know, it would be easier for me to sit there and feed this client and then not be messy. But how are they going to learn how to care for themselves whenever they go home? Same thing with your kids. Lord knows, whenever you've got a 18-month to 2-year-old, when they're learning to eat themselves, you learn to plaster plastic all over your walls and all over your floors and everything else. because you know that food is either going to end up on the floor or in the dog. So, and the dog loves it, but it doesn't help with that kid. But you need to make sure that you do what they need help with, but you never do more than what you have to do. Make sure that that patient allows themselves to learn to redo things. Let's get that one. Advocacy, the 4 dimensions, basically, you want to be an advocate, helping them to learn what's going on. You want to follow through or follow up, making sure that they've gotten the resources that they need. And then sometimes there's going above and beyond. I think we've all seen the stories, especially over at CMC Northeast, where they do the little stories about being a client advocate, making sure that patients are well cared for. You know, the thing is that you want to make sure that you don't enable pathologic choices, which I do sometimes by providing 10 to 15-minute breaks, because it takes a little bit of time to get to the tree and back. You know, basically we don't want patients to smoke in the hospital. It's better to provide them with a nicotine patch. It's better to, you know, make sure that they have adequate pain control, but you don't want to overdose them on those pain medications. With educating our providers, there are a lot of good advocacy groups, especially with mental illness. We've, you know, all seen the state of care of our mentally ill clients, either at CMC, at Northeast. There is no unit, okay? With Rowan, we have LifeWorks. You've seen the state of care at the VA. Are those perfect? No. But it's better than having none. One of the things that I'm hoping that will occur is that as the stigma of mental illness becomes lessened, because more people are recognizing it as a disease process instead of a deficit in moral character, I think that we're probably going to see more acceptance of your patients that are mentally ill. I think we're going to see more resources available to them. I think that one of the things we're starting to see in our society is that, you know, people are less accepting of insurance only covering 30 days of mental health care per year. It's ridiculous. I mean, if you've got someone that is acutely ill, 30 days in a year is nothing. And you guys saw the amount of return visitors sometimes on those units. And it's, you know, the VA's a little different system because there's really not that limit on there. But with regular insurance, there is that limit. Basically, when you're talking about professional and public advocacy, not only do we want to advocate for our clients, but we want to advocate for the profession of nursing. We want to make sure that we as nurses advocate for the groups of clients that don't have the resources that we have, specifically for your children and families. And I think that the project that the Honor Society has picked with CDAN is a great show of advocacy for those clients that have experienced interpersonal violence. Just as an FYI, the American Nurses Society Association, or the ANA, is a lobby for the profession and the clients. Now, with A&A as a national organization, it basically would advocate for the role of the nurse in healthcare system. Now, the A&A in such states as California actually is the lobbying union that those nurses use. So A&A basically acts as a union representative for nurses in some of those states. You know, we can all work as advocates for all of our clients. And a couple of things that you need to recognize before we talk about the 1990, the American Disabilities Act was enacted. And that is just to make sure that people have equal access to health care, that they have access to buildings, that they have access to things that they should have the right to. I mean, I'm sure maintenance is probably tired of me complaining about the handicapped access door not working. Yeah, I understand that it's a problem, but you know, the thing is that someone that's in a wheelchair could not get in those doors at this particular time. And I needed to make sure that they're aware that you guys need to watch that door to make sure that people that they can get into the building. It's also in a very horrible place. I complained about that, and believe me, I've had the city out here to look at it. It's that bench is 1 inch. If it was half an inch closer, it would be non-accessible. So I've already complained about it. Of course, they probably pay me to take that. It's the population I work with. I mean, I work with a lot of patients that are wheelchair dependent or have some disability that requires them to have limited access. So think about, I know not a lot of you would have problems, but think of someone with like a shoulder dislocation or someone that has rotator cuff. There is no way they can get those doors open. In fact, they had some little girl, I think, security guard says she weighed about 80 pounds and got stuck in between the two doors and couldn't get out. And he had to go rescue her to try to get her out of the door. You know, those are the types of things that we need to think about. Are we following what the American Disabilities Act says in our practice? Making sure that the place that we work, the places that we frequent, are following through with that. The 1991 Patient Self-Determination Act basically it's a law that basically says that patient has the right to determine what their care is. And even though that was one of a philosophy that a lot of healthcare agencies had, it became law in 1991. Now, with mental health issues or mental health settings, I think we've all seen that those patients are particularly vulnerable to abuse. Drug use, alcohol for favors, making privileges contingent on favors can be an issue in some areas. Inhumane facilities, sometimes physical violence and restraints are often a problem. Sexual misconduct. One of the things that we're starting to see, unfortunately, more and more, especially in nursing homes or mental health facilities, is a lot of the patients may have STDs. And you have to worry, is it sexual abuse from the staff or is it from fellow patients? consensual sex in long-term care facilities is not a problem. But if it's unconsensual, then it's termed rape, guys. And we need to make sure that our patients are protected from that. Other issues in mental health, unsuitability of staff members working with clients, lacking self-control. I think we all saw some behaviors in nurses that made us say, I never want to be like that. And I want you, as you progress through your career, I want you to remember those and try to figure out, how can I avoid being that nurse? Lacking patience, lacking understanding. Now, I'm going to tell you, one of the things that does help that is a lot of stress and staff burnout. The thing that you need to recognize is if you're getting burned out on this group of clients, then you need to switch. Come up with a whole different group of clients. Because that's one of the nice things about nursing, is that if you burn out on this, you can try something else, because there's a whole different world out there. And you can figure out what's going on with that. All right. All right. Let's go to this one. Specific areas for advocacy. Evaluating policies and procedures, and that may infringe on some of your clients' rights. What are some of the policies and procedures that you've worked with, either in your job or that you've experienced as a care partner or as a student nurse, that may have infringed on patient rights? Smoking, or the lack thereof. Okay? Yeah, we understand that smoking is not one of the things that you will see in a healthcare situation because it's non-healthy, but do people have the right to smoke? Yes, because it's a not an illegal substance. So that's one of the things. What about some other things that may infringe on clients' rights?
The one we see the most is making them stay in the bed because we don't have the adequate staff to get them up. So we put both rails up and we make them stay in the bed.
Yeah. Basically, bed alarms are a restraint, aren't they? Because there's not adequate staff in order to be able to care for that patient. What are some ways around that? Towel towel. And that is also a chemical restraint. Either hire more staff, or what might you want to suggest to the family?
To stay.
They can stay if they want to. One of the things that has changed in my lifetime used to be with hospital visiting hours. It was 11 a.m. to 8 p.m. No one under 12. And basically, it didn't. I don't care if your grandfather is dying. You cannot take grandchildren in there. That basically went from, a guard at the elevator and all entrances to prevent visitors to go into the hospital, to now it's like open season. Yeah, you can bring your 3-month-old in and see and whatever. And what we're finding is that now when hospitals basically impose much more restrictive visiting hours because of, say, for example, the flu that happened a couple of years ago, where a patient visiting hours where no one under the age of 18 could get in, we're starting to see a lot of backlash from that. One of the things that used to happen that's, evidence-based practice has changed a lot of that, because what we found is that having family there helps significantly in the way that these people get better. Number one, because you got to have them there to be able to teach them, because in 2 days you're going to be responsible for this person. And number two, one of the things that we're finding is that even in code situations where these patients are being resuscitated, especially in the emergency room, what we're finding is that patients' families deal much better with that outcome, no matter what it would be, if they see that everything has been done to try to help that person. Used to be that in the emergency room or the ICU is that if that patient started coding, the family went out. Totally. I don't care. Now, what we're starting to see is more liberal, that they're able to stay because they understand the process a little bit better if they understand what's going on with that patient. What other policies? Yeah. If you have a heart monitor, you can't take a shower. Do you know why that's the case?
Because they cost like $10,000.
Well, but the reason is you cannot monitor in the shower. The reason that they basically have, you can't take a shower to take it off is the insurance companies. Basically, the insurance companies set, because they pay an additional fee for telemetry monitoring, if you are able well enough to take it off for 30 minutes while you shower, then you don't need telemetry. And that is why that policy has changed, because they used to be able to. But the insurance companies basically said if you're well enough to take it off, you don't need it. So we're not paying for the additional fee. What about ensuring clients have the necessary information from informed consent? What changes have you seen in your short career? How many of you have ever read one of those consent forms that you sign for surgery? How many of you have ever read your operator manual on your car? Probably about the same number of people. Typically what happens is that when you see one of those consents, it's not in plain language. It's in legalese. And basically all they do is, what most people do is look at the doctor, the procedure, and the date. And that's what they sign. Because very rarely do people continue to read through that entire document. What do I mean by informed consent? Is it just the signing of that document?
The explanation.
Do they know the risks? Do they know the benefits? Do they know what would happen if this didn't occur? They also have the right to know who's doing the procedure and in what circumstances. One of the most uncomfortable situations that I've ever been in is that one of the physicians, the family was expecting one of the physicians to do surgery on their son. Well, he was down in the OR. They did, on the news, they did a live interview with his surgeon. So it was like, they came flying out of the room like, all right, who's doing surgery on my son because Dr. So-and-so is on TV right now? And it was like, okay, let me figure that out. And, basically what had happened is that, yeah, he had taken a break to do the live interview, but the family was PO'd, let me tell you. Who's taking care of my son while he's out doing this TV interview? And they had a right to be concerned. What about unsafe practices or unsafe practice conditions? Jeff talked about extra help. How many of you work with those wonderful grids that we have seen that have occurred in the past couple of years? What do I mean by practicing on the grid?
It's a ratio.
How many staff members you can have and so many patients? What's considered unsafe may be different in your definition versus someone else's. The only state in the United States that advocates or legally says this is the patient-staff ratio is California. Only one. So it really will vary. And a lot of times what you will find is that state boards of nursing will not intervene with what are unsafe conditions. Now, that doesn't mean that DHSR will not. DHSR, the Department of Health Regulation, definitely will, because they not only review hospital systems, but they review nursing homes or extended care facilities and things like that. So, you know, even though you may feel that it's unsafe, the Board of Nursing has no really impact on that. DHSR may. Let's talk a little bit about illegal responsibilities, and we talked a little bit about this with mandatory reporting. Impaired nurses, basically what we need to do is follow the board of regulations. Typically what you would see is that with impairment on the job, it should be reported to their direct supervisor. And it may be the responsibility of the facility to report that to the Board of Nursing. Now, if it's on the job, then definitely you follow that chain of command. But what if it's something that you recognize as a community that's not involved with your job? Whose responsibility is to report it to the Board of Nursing? Well, actually, it should be the impaired nurse as well as yours. Okay? Now, let me ask you a question. What if I have legal prescriptions for those medications?
Not supposed to take them while you're working.
If you're following the doctor.
I can still be impaired and still be following the doctor's orders. Okay? A legal prescription does not negate the definition of impaired. Okay? It's just like whenever you're driving while impaired. If you're under the influence of a narcotic, then you will still get that ticket. It doesn't really matter. If you're impaired to the point where you cannot follow your duty, then you are considered impaired, and that is not appropriate practice.
What about downsizing and not as much nursing staff as they used to be working nurses, 2 or 3 more shifts than they normally work and being sleep deprived?
That gets sticky too. I mean, sleep deprivation is probably just as much of an impairment as narcotics can be. What you have to do very carefully is to look at what your facilities overtime requirements are. Looking at the contract or the work agreement, because typically what you will find is that North Carolina does not have contracts since we are a right-to-work state. But there will be work agreements. The other thing is that you learn to say no. And that's a hard thing for a lot of people. Mandatory overtime gets very, very sticky. And that is going to be one of the things that you have to, look very carefully at what your work agreement is. I can see working one shift. I can see working, but one of the things that you will see is that you have to have breaks with labor laws, and I'd be very familiar with those as well. But yeah, sleep deprivation can cause impairment just as much as narcotics or alcohol. And in fact, the studies that they've done sometimes show that it's even worse than alcohol impairment. So, worry about that. All right, let's talk about values. Value systems, basically, these are beliefs or attitudes about the worth of a person, object, idea, or action. They can be unspoken, or basically we just unconsciously hold them. Our value system basically underlies all moral dilemmas that we have, and our values are often taken for granted. Typically what you'll see is that they form the basis of our behavior. And where we get our values, these are some of the plays. What about, let's talk about the time period in which you were raised. I mean, we have some people in here in their early 20s, and we have some people that are beyond their 20s. And I'll put it politely like that. What's the difference between some of the values that you see in some of the younger population versus our older or more experienced generation? Let's just put it as more experienced. Respect is what way?
Your elders.
Okay. What about this?
All the time.
Okay. Someone that's younger may not be upset that, I'm up here imparting my knowledge such that it is today. But I see a lot of you, on your phones. And to some people that would be a sign of disrespect, that you're not paying attention, but to others it may be that you're multitasking and looking up a word that I said that you may not have known.
That's wishful thinking.
That's wishful thinking, I know. But I'm giving you the benefit of the doubt. Let's just put it that way. Or you sit at the table and instead of looking up and saying, what do you think about so-and-so, you text the person that's sitting across the table. Okay? That's a totally different value. Okay? It's just our rule at the table is that the phones go in the other room. They don't get answered. Because the table is to talk, not to watch TV. It's to talk. Catch up on all your day. To have someone to complain to commiserate with. Okay? What about our families? What are some of the values that we get from our families? They all politicians talk about family values. What does that mean? Used to be, what did a family consist of? Mom, dad, and 2.3 children, right? All right, so what are most of our families now? The majority of our families are single-parent families. So those values have switched. And I think that they will continue to change as we go through as a society. Books. What kind of books were you assigned in school?
Not paper.
Shakespeare.
Not paperbacks, they were hardback books.
Got to see that they had it the year before you.
Yep.
Now they don't even.
Now they don't have books, they have tablets. Textbooks are a ripoff. I totally agree. My daughter's textbooks for one semester were $3,000, and they would not leave the next semester. The other thing is, the different books. How many of you were teenagers when Harry Potter came out? Okay. 85.
They came out in 85. Oh, then I was.
I don't even remember. A lot of people don't know what.
Don't listen to your parents. Well, let's look at some of those values with our age ranges. Typically what you find that these are your influences. At ages 1 to 7, your parents. Age 8 to 13, teachers, heroes, sports, music, and TV. That's why a lot of people had major issues when Elvis came out because of all the gyrations that he was doing. Do you know that on the first Ed Sullivan TV show that he was on, they would not show him from the waistband? Just from headshot. Ages 14 to 20, basically we're talking peers. And then usually with your values at ages 21, they're established, but occasionally you will test them. And I think that what we find is that our values will change as our society changes. So what are some of the values that we see in nursing? What are some of the values that you are learning as you're progressing through school here? So be honest. Honest. Doing no harm. Even if you want to. What else? Reliable. Being reliable.
Respectful.
Respectful of clients' rights and I'm sorry? Safety.
Trustworthy.
Oh yeah, that's one of the things we pound into your head, isn't it?
Non-judgmental.
Yeah, the thing is, this morning, whenever I crossed that little bit of ice, oh, I didn't. Yeah, about that. Professional values, basically things that are important by a group. Autonomy, integrity, and commitment. One of the things that used to be, whenever I first started nursing, is that everyone had to write this essay that said, I want to be a nurse because. And then you would get all of these essays that said to help people. Okay? Well, what's happened is that nursing as a profession has gone from a nurturing, helping, to sometimes is considered a job. Okay? Yeah, I can see that some of that is good, some of it is not so good. I think that one of the things that we need to instill into nurses still is, yes, it may be a job, it may be a reliable job, but it is still a profession that you have to advocate for those clients and to make sure that they're cared for and that their values and their beliefs are cared for as well. Let's skip to where we talk about professional values, because that's really what I want to focus on today. Basically what you're seeing, the American College of Nursing has 5 values, and these are them. Altruism. What do I mean by altruism? Anyone have an idea? Doing good for others. That's exactly what altruism means. It means devotion and selfless concern for others. What about autonomy?
Right to yourself.
Self-determination is the better definition. Okay? Autonomy basically means that you have the right to determine what you're going to do. What about human dignity? How would I respect someone's human dignity?
Embarrass them because of things. Yeah, give them
Privacy.
Keep them covered. Basically, you are, with human dignity, what you're doing is respecting their worth and their uniqueness as a person. It may be to keep them covered, to keep them from becoming embarrassed, to make sure that they are not treated as the patient in room 42. To make sure that they are treated as an individual and not just another patient that has to be cared for. What about integrity? Honesty. Basically, we're following what the code of ethics might be and making sure that that patient is well cared for. What about social justice?
treat people equally no matter what they're.
Correct. We want to uphold moral, legal, humanistic principles and make sure that we try to eliminate health disparities so that patients have equal opportunities for health care. And those are the values that we see as nurses. Okay? Now, when you're talking about values clarification, one of the things you want to do is list what your alternatives are. I mean, it's just like every situation is not going to be black or white. It's going to be shades of gray. And not 50 shades of gray. But we want to list what those alternatives are and figure out what are some of the possible consequences of each of our choices. We should be able to choose freely and feel good about that choice. Hopefully what we will see is that based on our values, we act in a particular pattern, that we make similar decisions every time we have to make a moral, ethical decision. Now, with ethics, some of the meanings that you'll see a method of inquiry that helps people to understand morality of human behavior, the practice of beliefs of a certain group, expected standards of moral behavior of a particular group. And nursing has a code of ethics that, as nurses, that we accept that those are the ethical principles that we're going to follow. With morality, sometimes what you're going to see is that that's going to be personal standards about what's right and wrong in conduct, character and attitude. Typically, when you're talking about moral values, you're talking about good, bad, wrong, what, should, ought, could, would, so to speak. With moral decisions, often what you're going to see is that the nurse may be caught between a bunch of people. And some of those are going to be very, very divergent. What someone may feel is the right decision for this patient in this particular situation may be the wrong decision for you as the nurse, or what you feel that the patient really wants. One of the things that I found very interesting when we're talking about moral principles and moral values, you know that CHS, or Carolina's healthcare system, bought Mercy Hospital. Okay? Who was the original owners of Mercy Hospital? Do you guys know in Charlotte? Actually, it was not the Catholic Church, but it was the Sisters of Mercy Convent. Okay? So they owned both Mercy Hospital in downtown Charlotte, and then they owned what now is CMC Pineville. It used to be Mercy South. What do you think was written into the purchase contract for both of those hospitals? Exactly right. There is a clause in the contract that abortions will not be performed at Mercy Hospital or CMC Pineville. And basically the contract is written such that if that is the case, then it will revert back to the Sisters of Mercy. So, what do you think happens if there is a case where an abortion has to be performed to protect the life of the mother? They have to be transferred to CMC Maine. Okay? And that is written into the contract because the sisters felt so strongly about that moral principle that followed the teachings of their church. So there are a lot of things that you will see. One of the things that you will have to figure out in practice is, what are my values that I am not willing to compromise? Okay? If you are working in a facility that does abortions and you feel strongly that you cannot participate in that, then you have to make that decision up front. You need to let those feelings be known that I will not participate in those procedures. Well, that's well and good, but if that's what the unit does specifically, then you need to think about another position. Okay? Some of the other things that you're going to have to think about when you're talking about moral decisions are these things. These are some of the moral principles that we will have to think about whenever we're caring for patients. And number one is autonomy, and that's the right to make their own decisions. Inward autonomy is if the individuals have the ability to make their own choices. Outward autonomy is that the choices are not limited or imposed by others. Now, sometimes what you will find is that, yeah, we may be autonomous, but we have to work within the legal system. There are laws that prohibit us from making choices, sometimes for our own good. Non-maleficence is another moral principle. That's a duty to do no harm, and it can mean intentionally causing harm, placing someone at risk for harm, or unintentionally causing harm. Another one of the moral principles that you'll see is beneficence, and that means doing good. Justice is fairness. Fidelity means faithful to agreements and promises, meaning that if you tell that patient, I'll be back in 20 minutes, that you're back in 20 minutes. Or you poke your head in and say, I can't stay very long right now, are you okay? That may be what you have to do. And then, of course, the moral principle of veracity means telling the truth. Those are the basic principles behind the Code of Ethics for nursing. And along with that, it means that being accountable and answerable to oneself and to others for your own actions. Meaning that if you screw up, you admit to it. And you are able to correct that behavior and recognize that what you did was wrong. You're accountable for your actions, and you're liable with the performance of duties for a particular role. With those codes of ethics, it's moral judgment over time. And one of the things that will happen is that as our society changes, our morals and values are going to change. The way that we care for cancer patients has dramatically changed in the past couple of years. The past 20, I will tell you. It used to be that a lot of physicians would not tell their patients that they had a terminal illness, because they felt that it took away all hope and that, they really just didn't need to know. But what do we see now? Will physicians hold back? I'm sorry, this is going to be a terminal illness and you're going to die, whatever. Do they refuse to tell those patients that now? No. Typically what you will find is that some families would want the physician to do that, but rarely will you have physicians that will do that. Alright, some of the rest of this. Let's talk about ethical dilemmas and how you solve those. Basically, that's choice between actions and conflict with the needs of one or more persons. Basically, with ethical dilemmas, you're going to see that it may be your personal values or those of another person or the organization, so that you have to come up with a way to figure those out. The better way to do this is look at these questions. What are the medical facts? Looking at patient condition and treatment options. What are the psychosocial facts? What is the emotional state of the client and family? What is the support system? What are the financial concerns? What are the client's wishes? And then what values are in conflict? Looking at those questions will help. basically one of the things you're going to do is to reflect on what values you have about life, health, illness, and death. Think about this. Can a nurse that smokes, can they effectively help a patient stop smoking? Or whether a nurse that's overweight can help someone that needs to lose weight? Can someone that opposes the use of contraceptives effectively teach someone about family planning? Some of the ethical issues that we see are these. Used to be HIV/AIDS clients. It used to be one of the things that you would see was that a lot of times you would see some of the same paranoia and panic that we're starting to see right now with these Ebola clients that are coming into the United States. I can remember the first HIV positive client that we took care of. Poor guy was just sitting on a bus trying to get to Miami, and somebody on the bus got into a fight, and gunfire was exchanged, and the poor guy that's just sitting there gets shot in the head. He was HIV positive, and that was the first patient that we'd ever taken care of that was HIV positive. This was very late 70s, early 80s. And it was one of those things that, you know, we looked like we had the Ebola suits on. Because it was just something new and scary. But now caring for HIV AIDS clients is become more of a routine. And what we're seeing, you know, now is that whenever you first saw these patients with HIV AIDS, it used to be it was a death sentence. Now a lot of these patients are living 20 years and longer with some of these effective medications. You know, abortion is one of those issues that has a lot of moral and ethical issues. Organ or tissue transplants. There are a lot of religions that do not allow for organ or tissue transplants. Your patients that are Jehovah's Witnesses do not take blood transfusions. End-of-life decisions. What about this, the Maynard girl that just effectively ended her life because she had a terminal illness and she wanted to go out on her own terms? You know, there are 5 states in the United States that do allow for physician-assisted suicide. And I think that, you know, back in the day when this first came out, you know, we had Dr. Jack Kevorkian, Dr. Death, he was termed. And he actually went and spent time in prison for physician-assisted suicide. It was not legal anywhere in the United States at that time. But now there are 5 states that it's legal. And I think probably with this young, attractive woman in her situation, I think we'll probably see a whole lot more discussion about that in the future. Advanced directives. I mean, it used to be that very few people had advanced directives, and then it became one of those things that that hospitals had to ask. It was a mandate from the United States government that you had to have ask if people had advanced directives. I can remember my uncle was freaking out. He cut his finger and went to the emergency department to get stitches, and they asked him if he had advanced directives. And he says, "Am I going to die or what?" But, no, you only need 2 stitches, but we have to ask. And a lot of people basically look at those advanced directives as, well, am I going to, instead of recognizing these are what my wishes are if this situation occurs, they can, a lot of things that came out with the Obamacare or the Affordable Care Act is that there were a lot of concern that we would have granny killings or death committees because of the amount of resources, lack of resources that we've got. And one of the things that, you need to think about as a nurse is that because we have limited amounts of resources, who is the better candidate to get this kidney? Okay? Is it that 53-year-old that had diabetes, or is it this 21-year-old that killed their kidneys by taking NSAIDs? And it's one of those things that there's a lot of moral, ethical issues related to transplants and who is the more severe candidate. Resource allocation is going to be one of the things that we're going to see in the future. One of the things that you will find is that the majority of resources that we as a society expend are for the people within the last 3 months of their life. And I think that we're starting to recognize that a lot of times that full-out medical assault sometimes to try to save these people's lives sometimes is a futile attempt. Depends on how that family feels, depends on how that medical staff feels. I worked with a physician that would rarely ask to make patients a DNR until he got into the situation where his dad was very ill. And he was coded almost 10 times during that situation. And what I saw was a 180-degree turnaround in that physician. And he became an advocate for DNR orders for patients instead of avoiding the situation. It was his mom that did not want to make his dad a DNR, but he was coded at least 10 times during this situation. And he saw what effect that had on his family, and he changed his approach traditionally. Other ethical issues, of course, are breaches in client confidentiality. Remembering that HIPAA is a law that we have to follow, making sure that we keep client information confidential, making sure that we follow through, because it's a very big trust issue with our clients. How comfortable do they feel giving me this information if they cannot trust me to keep it confidential? It's sort of like for a teenager that comes in with an STD or someone that comes in as pregnant. A little bit different in the situation. STD, I have to report that an STD was present in a patient in this county. Don't have to give a name. But as a healthcare provider, I cannot say to that teenager's parent, your daughter has an STD, because that is privileged information. The same thing with pregnancy. I cannot tell that parent, even though they may be a minor child, that their daughter's pregnant. So it gets very, very sticky, and one of the things that not only do you have to worry about is ethical issues, but legal issues and following through with what you're going to be doing, as well as what are some of the situations that you're going to see with your institution, because they may have very, very specific policies and procedures that you're going to have to follow.